Hello everyone, welcome to Coronet. Welcome to the live class series. We'll be dealing with maxillofacial trauma. So we're going to be dealing this topic under 5 to 6 sessions. So today, let's start off with that topic in trauma, which has been often neglected by students. But the questions have been asked repeatedly, and this is going to be about the primary assessment and initial treatment that can be given when a patient with trauma arrives. Okay, so let's just start with the first question. Which of the following is not included in Glasgow coma scale? So I'll read out the answers. Please be more interactive and give me the answers and what you think is the guess and why. You can put it up in the comment section over there. So yeah, let's go through the options over here. A is eye opening, B verbal response, C motor response, and D pupillary size. It's a very straightforward question, but why I'd like to stress about this is they have been changed in the Glasgow coma scale as well. So I'd like to bring it to your attention. Yes, the answer is D. Pupillary size is not included in the original Glasgow coma scale, which was given long back in 1974. But in 2018, they've come up with a new score where they've added pupillary score as well. So just in case if they're going to ask you about that, just make sure what coma scale they're going to ask. So the one in 2018 that I'm talking about, that is going to be called GCSP, that is Glasgow coma scale, which includes pupillary score. That actually includes even pupillary reactivity. Okay, I hope that is clear. If it's plain Glasgow coma scale, just go with EVM, that is eye opening, verbal response, and motor response. I've put up the score over here. The another question that is important over here is what is the minimal score that is given? Just make sure you remember that every score, that is eye opening, verbal response, and motor response, starts with 1. That is, if there is no response, it's not 0. Just make sure that you put the option as 3. So minimum is 3, that is totally unresponsive, and maximum is 15. Another thing I'd like to stress is what are the patients that you actually look into Glasgow coma scales for? Not every patient you encounter, you go for that, right? So let me tell you something. It's just to assess the level of consciousness of the patient where you suspect a acute brain injury or a patient with a head injury. Any patient that comes to you that has loss of consciousness, you're supposed to go for this. Even if there is no loss of consciousness, if they have any head injury, this is how you're supposed to grade. I hope that is clear about GCSP as well. Shall I go ahead? If you have any doubts, please put in the comment box. Okay, moving forward then. What is the first step in management of head injury? Option A, securing airway. B, IV mannitol. C, IV dexamethasone. D, blood transfusion. Okay, so I'd like you all to know when each of these steps is necessary. Can you hear me now? Is it better? Just let me know if I'm audible. Okay, so the answer over here is securing airway. I'm pretty sure all of you know it is the protocol that has to be followed, that is airway, breathing, and circulation. So let's focus on the other options that's been given to confuse all of you. So when there is a head injury, why is there a requirement of IV mannitol or IV dexamethasone? Can anyone tell me the answer? So when you look at such options, you think that, okay, fine, let's first connect IV mannitol. But the most important part is to secure the airway. Only then is when we can save the patient, which is essentially the first step you're supposed to do. But where is IV mannitol given in head injury cases and why is it essential? This is something all of us need to know. So can anyone tell me why? Or just take a guess. What is mannitol and how does it function? Anybody? Okay, so when there is a head injury, there is something that raises, what is that called? The pressure, intracranial tension. It is the intracranial tension that increases. And why is that so important? And how do we identify? I'm sure you guys know that whenever there is a head injury, patient complains of headache and then vomiting, which doesn't have. Yes, intracranial tension is the answer for that. So, yeah. So, patient complains of headache and then vomitings, which doesn't actually have nausea, it's straight away vomitings. And then they can be ocular palsies. And have you heard of something called papillary edema? Yes, intracranial pressure increases. So, it is very important for us to treat it. If we don't try to reduce the intracranial pressure, what can happen? They can be not only just optic disc swelling, basically everything inside the head. If the pressure increases, what is going to happen? So that is a very dangerous situation, which is why one of the important things that is done immediately when there is head injury is IV mannitol. Dexamethasone also is supposed to reduce the intracranial tension, but the recent studies show that there is not much of a role. So basically, IV mannitol is a drug of choice. This is another very important question. So make sure you remember that. And blood transfusions, when do you expect a head injury patient to go through blood transfusions? Anybody? I think that is the next question that we'll be dealing with. So we'll deal with that later. Okay. Is this clear? Just make sure you don't get confused based on the kind of options that are given. It is always airway. It is gold standard. The first thing we have to do is make sure airway. Severe bleeding. So that is the next question I have placed. So let's see. Patient in shock with gross comminuted fractures immediately requires what? What is the first treatment that you do? Basically, gross comminuted fracture. So it can be a panfacial trauma. The patient is going to bleed a lot. So obviously, there's going to be shock. It is what you suspect immediately when such a patient arrives. So what are the options? Let's go through it. A is normal saline. B is whole blood. C, RL, that is Ringer's lactate. And D, plasma expanders. So, yes, can anyone put the answers? Can anyone guess? With the can anyone tell me why? Why is it that, why do you think it is RL that has to be given and not whole blood? And what are plasma expanders? Anybody? Anyone that can tell me why you think it is RL or C? I can see 4 to 5 people answering. What do you mean by fluid management? The rest are all also fluids, right? Plasma expanders, whole blood, and NS. So you need to know why exactly you're giving that as well. Okay? The plasma expanders. Now I'd like you to tell me what are plasma expanders. So there are two types that everybody know of. Colloids and crystalloids. Very good. So what are colloids and what are crystalloids? Just name them. That's okay. I don't expect you all to know how they work and how it increases the plasma volume. So what are colloids and what are crystalloids? Name few crystalloids that you know of. Very good, Rupasi. Go ahead. Anybody? Few colloids and crystalloids. Just name one or two. So what is blood? Is it colloid or crystalloid? Yeah. So dextrose is which one? Dextrose and normal saline that is usually given. Is that a crystalloid or colloid? It is a crystalloid. So crystalloids are going to be normal saline, DNS, and RL, that is Ringer's lactate. Okay, all of these are soluble in water, and these are the ones that are given for initial resuscitation. Okay, initial resuscitation. When it comes to colloids, yes. So that is dextran and then albumin, gelatin. Very good. Those are the ones. And even blood. So these are water insoluble, and these are the ones that help in increasing the plasma volume. So now, in this case where there is gross comminuted fracture, what is the shock that we are expecting over here that you want to give RL of all the crystalloids? What are you expecting over here? What kind of shock is it? Because this is an immediate reaction. So immediately, what do you want to do? What is the type of shock? Yes, it is hypovolemic shock. So let's move ahead and just a brief about why we give ringer's lactate. So basically, the most important point over here is the physiological composition. It is similar to ECF. So what are we going to do? We have to rapidly try to increase the volume of ECF. Okay. In, to increase the intravascular volume. Basically, if you give 1 liter of RL, it is going to increase the intravascular volume by 200 to 240. So when there is case of severe bleeding that is happening and patient is going into hypovolemic shock, this is the reason it is important. Don't directly go for NS or DNS as one of the options. Okay. And ultimately, if after this is when they have to decide based on other parameters if blood needs to be given. Okay, but immediate, if they are going to ask immediate, go ahead with RL. Okay, I'm moving forward since all of you have, I presume you've understood. Okay, this is another simple question. It's just a picture based question, but let's deal with the rest of it also. So what is this? What is it that can you see here? What is the name of the sign? A battle sign, Coleman sign, Guerin sign, and target sign. It's pretty simple. I'd like you all to know why it occurs so that you'll never forget why it happens. So, what is it that you can see over there? It's a typical classic feature which you're never supposed to forget and miss when you're examining. Anybody? Guerin sign. Go ahead. I want all of you present over here to take a guess. If you could explain why it is and why it happens, that's even more good. Go ahead. Okay, so someone has said it's Guerin sign seen in Leafort 1 fracture. So, what site are we exactly seeing over here? Can you identify the structure that is present over there where the finger is resting? Is it anywhere related to maxilla? Rupture of greater palatine artery. So, one second. I'd like you all to focus on this. I think it is not that clear. Just look at this part over here. What is this over here? Can you identify what this is? Or over this part at least? Isn't this the tongue? Yes. So this is the sublingual hematoma that we're seeing. So if you're going to say it's Leafort 1, it's totally the opposite of it. This is not the greater palatine. Yes. So yes. Did you understand now? So this is the tongue. Greater palatine foramen, this is not what it looks like. It's a typical sublingual hematoma. So what is the name of the sign? Sublingual hematoma, it's pathognomonic of mandibular fractures. Why does that happen? Whenever there is a breach of lingual cortex. So basically, when there is a fracture in the mandible and there is a breach of lingual cortex, where lingual cortex is also broken, is when the hematoma. What is hematoma basically? Hmm? Anybody? Hematoma is just a collection of blood. So where is it? So when there is the lingual cortex that is breached in the inside is where the blood escapes and it's going to go to the space below the tongue. That is the sublingual hematoma. The answer is Coleman sign. Very good. So yeah, rupture of blood vessels. But for here, the most important part is even if there's a rupture of blood vessels when there is a fracture, how does it move into the lingual sublingual space? Basically, because of the lingual cortex. This is the most important thing. Please remove that. Remember that. Yes, yes. Easy passage of fluid and blood in the lingual side because there is a breach. Okay. Now, what is battle sign? So many of you all spoke about that. Battle sign and Guerin sign. Now, just identify and tell me what is the left one and the right one. We'll just go ahead. Yes, Coleman sign is the answer. Now, can anybody tell me what is the sign in the left one? Left picture. You can see there is a crescent shape ecchymosis. Mastoid hematoma. What is the name of it? Battle sign. So, can anyone tell me what's the difference between ecchymosis and what's the other one? Hematoma. We just spoke about hematoma is a collection of blood. Now, what is ecchymosis? Mastoid process sign. So, yes, the left one is battle sign. Where is battle sign seen? You can typically see the crescent shape ecchymosis over here behind the ear. So, it is also seen. Yeah, can anyone tell me where it is seen? Right is Guerin. Very good. Yes, that's a greater palatine foramen. What you can see over there in Leaford 1. Someone has already said that. Ecchymosis is rupture of capillaries causing discoloration. Basically, rupture of capillaries. Are you sure about that? Basically, just remember it as a subcutaneous bleeding. And what about the size? The most important part is it is more than the discoloration is more than 1 centimeter in size. Okay. Extravascular and intravascular. Intravascular in the sense that the bleeding is inside the blood vessel. Is that what you're trying to say? No, that's not right. Just go and look up the definition once again. I'm sure it is given in all textbooks. Bluish discoloration indicate, yeah, okay. So it indicates subcutaneous bleeding and the skin discoloration. It should generally be more than 1 centimeter. Okay, we're going off track. Now tell me, where is battle sign seen? In what kind of cases? And let's come back to maxillofacial trauma as well. What sort of maxillofacial trauma do you expect this to happen? Sternocleidomastoid muscle ruptures? No. Where is that is not at all the case. So because it's in the mastoid process, you can just take a guess that way, but that's not the case. So basically, whenever there is the most common reason why you can see battle sign is when there is a base of skull fracture or fracture of middle cranial fossa. But apart from all of that, condylar fracture. So if there is a condylar fracture in our scenario, that is maxillofacial surgery, when there is a condylar fracture, why is there a hematoma in the region of mastoid of all places? How does that occur? So basically what happens is the hematoma, it goes downwards and backwards below the external auditory canal. So that is why hematoma that is created due to the condylar fracture itself goes downwards and backwards, and this is where it settles near the mastoid region. So when you look at it, you might think there's something wrong with the mastoid, but generally that is not the case. Okay, always check for condyles. They'll already been bleeding from the ears, so that's another sign when you look at condylar fractures as well. I hope this is clear. So this is pretty much the right side. It's pretty much clear. It's Guerin sign, greater palatine foramen, which is seen in Leaford 1 fractures. Is it clear? Escape of blood, yes, that occurs downwards and backwards. Just remember that condylar fractures, when there is a hematoma, it tends to move in this direction and settles near mastoid process, forming a crescent shape ecchymosis. Okay, is it clear? If you have any doubts, ask away straight away. Okay, or we can move ahead with the next question. Is it fine? Yes, cranial base, middle, third. Basically, it is middle cranial fossa, cranial base fractures or middle cranial fossa fractures. Okay. The next one. This is just the options that are confusing. Just take a look at it and tell me. It's a very straightforward question. In a patient with head injury, which is more important to note first? The light reflex, pupillary size, corneal reflex, ability to open eyes. I want all of you all to answer this correctly. Okay. Don't look at what others have been answering. Just go ahead with what you feel like is right. Okay. I want everyone to answer it right. Light reflex, pupillary size, corneal reflex, ability to open eyes. Basically, they tend to put options in such a way that it is confusing, but it is a very straightforward question. I can see in the comment section that it's been very uh, mixed opinions about it. Okay. Everyone done with guessing? Okay. So, what was the first thing that we do in Glasgow coma scale? Patient with head injury, you know there is a known head injury. First thing you do is assess them through Glasgow coma scale. What is Glasgow coma scale? What is the first one? The answer is D. Okay, ability to open eyes. If they're not opening the eyes, none of it matters. Okay, if they're able to open the eyes spontaneously, not verbal, the first thing you check is eye. Okay, first thing, if they're opening eyes spontaneously or to commands or to pain, when you elicit pain, if they're opening the eyes, that is the response. That's important. Exactly. So it is eye response. Motor response is very important as well, but right now we are dealing with this. Okay, motor response is how they usually communicate. That is all neurosurgeons terminology. But for us, when there is a head injury, first thing you have to see is if the patient open the eyes or not. If there is corneal reflex or not is irrelevant if they don't open the eyes. I hope this is clear. Okay, let's move forward. Which of the following indicates air obstruction? Strenuous breathing, low pounding pulse, increased pulse rate, and decreased BP. Okay, so air, the first thing that we've established is that we have to make sure there is a patent airway. There shouldn't be any obstruction for the airway. So how are we going to indicate? There might be, so basically I hope you guys understand that what can be the ones that can obstruct in case of a head injury when there is a head and neck trauma. They can be anything as small as loose dentures or or loose crowns from small mobile fractured segments. Okay, any of this can cause air obstruction, and imagine if there is a small prosthesis that is obstructing it. So how are we going to remove it? We just have to identify that there is air obstruction. How do we realize that? It's not the pounding pulse or pulse rate or BP, but it's the strenuous breathing. Let me make this clear: airway, breathing, and circulation. There has been other protocols where they say circulation is also first, but ultimately everything should be simultaneous. Though it is given in a flow chart form which says first is airway, then take care about breathing and circulation, everything should happen at a time. So how do you understand there is strenuous breathing? You can see that patient is not breathing properly, you can hear it also. What you do immediately, wipe, it's called swiping motion. You just put a finger inside the throat and check if there is anything obstructing, any small prosthesis. That is where they'll call maxillofacial surgeons if there is such a thing. Mostly if there is an anesthetist available, immediately what they do is they try to intubate. If there is such a case, they remove whatever air obstruction is present, whatever obstruction is present. But if there is loose prosthesis that is partly attached, who is going to take care of that? Nobody will understand. So that is where we come into place, and strenuous breathing is what we have to observe. Don't forget everything else about pulse and decrease BP and all that. Make sure you check the BP. Understood? So this is the option you should go for. Never get confused. It's a straightforward question. Just because they talk about pulse, you shouldn't think that is the answer. Okay. Next one. This is something that has been asked many times. People still tend to make mistakes, so I place it here. Make sure you remember it. Daily sodium requirement of an average patient with maxillofacial trauma. So do you guys think that patients with trauma need an excess of sodium or less sodium or the same as any other patient? Just remember it in a way that yeah. So yeah, you guys go ahead with the answers. I'll tell you what is the right answer. Okay, most important thing for us is to know about sodium and potassium. Other than that, we keep giving NS also, so we have to monitor how much sodium we are giving, because hypernatremia and hyponatremia is something we wouldn't want to be dealing with in a case of maxillofacial trauma. So we have to we have to make sure it is optimal. So, okay, the answers. Okay, so anybody else? Can anyone say why it is what they think it is? Okay, just tell me the normal daily requirements of sodium, then we can go ahead. Normal daily requirements. I know this is a very dry topic when we talk about nutritional requirements, but this has been asked, so we have to make sure we remember. And especially when it comes to sodium, we have to be very careful. Okay, so let me tell you the normal daily requirement of sodium in millimoles, that is. So it is roughly, remember it as 1.5 to 2 millimoles per kg per day. All of you make a note of it. 1.5 to 2 millimoles per kg per day. So when you look at this, what do you think is the answer? It is C. Okay, 100 millimoles. When it comes to potassium, this is another important question. So potassium daily requirement in case of trauma is 60 millimoles. Okay, that is why they've given that B option as well. A and D is to just confuse you guys with the numericals. That's it. Okay, so 60 millimoles per day. Okay, that is for potassium. So the answer is C. Is it clear? Generally, what we tend to do is give a slightly higher dose of sodium compared to the normal dietary intake. Okay, slightly higher. So 100 is fair enough. 100 millimoles per day. Understood? I hope it's clear. Why do we need more in case of trauma? So what is the kind of the point is we are not going to a higher increase in sodium as well. If you can see, we're still trying to maintain it in the normal doses, but generally it's not like it's in case of cancer where there is cachexia. But when there is maxillofacial trauma, what is the body trying to go under? Basically every part of it goes into healing. So that is when we have to make sure that the dietary requirements have been met. Another thing is maxillofacial trauma, the major important thing is how are we going to give the diet? Understood? So the patient won't be able to eat, they might be under maxillomandibular fixation. So generally whatever they'll be taking daily also, they can't take that much through dietary intake. What we have to do, make sure we have a proper chart, and it should be a high end of the normal. So suppose if the patient is around 60 kilos or something, we talked about 1.5 to 2 millimoles per kg per day. We make sure at least he has 100 millimoles per day. Understood? Yes. Okay. Is that clear? Shall we move ahead? Okay. So the next one, CSF leakage is diagnosed by all except. So this is a important question. So have you guys heard of CSF rhinorrhea that happens? So that is very important. Where is it that we see CSF rhinorrhea? Why does it occur? So there are two questions. Why does it occur? And what are the cases? Increased glucose. Okay, just go ahead with the answers. But I want you to answer, where do you see CSF rhinorrhea and why does it occur? Anterior skull fracture. What do you mean by anterior skull fracture? Default 2 and 3 due to? Yes, go ahead. Please give me the answers. I like how you guys are interactive. Cribriform plate. Yes, that's the most important thing. So where do you expect CSF to be leaking into the nose? That is when there is a fracture of cribriform plate of which bone? Just finish the answer completely. Cribriform plate of ethmoid bone. Okay. So that is seen in, yes, very good. Cribriform plate of ethmoid. So that is seen in, someone has mentioned it, Lefort 2 and 3. We'll deal about this in detail about the fracture lines and all when we deal about mid-phase fractures, okay? But other than Lefort 2 and 3, what else? Naso-orbitoethmoid complex fracture, NOE. Yes, when there is NOE fracture, that is where we expect CSF leak, okay? So, so that is going to be CSF rhinorrhea. And CSF rhinorrhea can be diagnosed by all except. This is very standard question which has been asked many times. So when we spoke about Coleman sign, I included target sign. We'll speak about it now. Okay. So the answer to this is D. increase proteins. So basically, I want you guys to remember that beta 2 transferrin is the most widely used. I mean, it's sensitive and specific as well. So 100% diagnosis is through beta 2 transferrin. Basically, how do you find out? There are many ways to find out there is CSF leakage. The most easiest thing is patient will be having running nose. Okay, so the running nose, wait, let me show you the picture. And when it is collected, this is what happens in a pillow or a handkerchief. So they can be blood, mixed, discharge. So how do we know the difference? This is what happens. So blood will be in the center and CSF settles in the periphery. This is why it is called targets or bullseye sign. Basically, it's because of the differences in viscosity is why CSF settles in the periphery like this. I hope this is clear. Okay. And beta 2 transferrin is, like I said, it's the most confirmative test to understand the CSF leak. The answer is D, increased proteins. So the rest of them indicate that there is CSF leak in the mucosa, in the mucus that is collected, that is nasal secretions. Okay. Let me tell you something. So is it normal to find glucose in CSF? Anybody? So it's written increased glucose, and I've told the answer is D. So is it normal to have glucose in CSF? What are the normal levels? Just remember, glucose in CSF is normal. Yes, it is normal. It is 50 to 80 milligrams per 100 ml. Okay? There is CSF. So basically, when you collect the secretions, in the nasal secretions, do you tend to find glucose? Because there is CSF, you see that there is glucose present. Okay? That is how you find out that there is CSF rhinorrhea. The secretions that actually have CSF, that is how you find out, because there is increased glucose levels. Normally, CSF contains 50 to 80 mg per 100 ml. Okay, make a note of that. So this is why. Increased proteins is not diagnostic at all. So there is nothing to do about proteins when it comes to CSF leakage. Okay, so that is not diagnostic. Understood? It's just a matter of elimination. Just make sure you know all the other three, because they've said it's increased glucose. Just don't get confused, because normal mucus secretions aren't supposed to have this amount of glucose. So if there is this much amount of glucose, that means there is CSF. Okay. And like I said, ultimately when you suspect it, you go for beta 2 transferrin test anyways. So these are the ones, all three, which are confirmative. There are other tests as well about handkerchief test and all. Go ahead and read about them. It's a very interesting topic. Understood? So you guys understood about CSF rhinorrhea, right? Okay. Answer is increased proteins. Okay. Going ahead. In a patient with maxillofacial trauma where cervical injury is not ruled out, intubation of preference is. So this is very important. Any case of maxillofacial trauma, unless it is proven otherwise, we have to treat them as if all of them have cervical injury. Okay. So we have to make sure that there shouldn't be too much movement as well, because it is not ruled out completely, cervical injury. So yeah, let's go to the options. Laryngeal mask airway, B, normal laryngoscopy and endotracheal intubation, C, combi tube, D, fiber optic intubation. Okay, just read the question and answers properly, all the options, and tell me, why do you think it is? What is the answer? So we spoke about laryngeal mask airway in the last session where we dealt about armamentarium. I think I've spoken about that then. So I'm sure all of you know what it is. It's a supraglottic airway, right? LMA. Okay, I can see varied answers. So all of you, please pay attention. Where cervical injury is not ruled out. That's the most important point. So when we're trying to do normal laryngoscopy and endotracheal intubation, a little manipulation of the chin and neck is essential or not? Yes. So what is the safest over here? We need direct visualization of the vocal cords and direct confirmation that endotracheal tube is placed in position. So the best option over here is going to be fiber optic intubation. Okay. Why are we going to go for fiber optic intubation? Like I said, we can't do a lot of manipulation as in case of normal endotracheal intubation. And what are the chances? So basically, when there is maxillofacial trauma, the airway is going to be collapsed no matter what. And for that, we have to do, you guys know about this, right? The head lift, chin tilt, and jaw thrust maneuver, and all of that. But do we do that in case of cervical injuries? We have to be extremely cautious. So it is not easy to do endotracheal intubation the normal way. And laryngeal mask airway, we can't be 100% sure about the placement as well. Other than that, like I said, again, it's a cervical injury. Okay. So the treatment of choice over here is going to be fiber optic intubation. Yes, you can be 100% sure the visualization is going to be direct. The most important point over when there is intubation is to make sure that ETT, the endotracheal tube, is placed. Wait, I have a picture. Let me show you. Yeah. So this is the normal endotracheal tube. We have to make sure they are placed between the vocal cords. That's the most important point. And look over here. We have to make sure that the cervical spine has to be stabilized. And this is laryngeal mask airway, which is supraepiglottic. Understood? And this is a combi tube. Anybody has an idea what is a combi tube? When there are when the chances of intubation is very difficult, when you see that it is difficult, what it does is a combi tube. It has an esophageal tracheal airway as well. So basically, what happens? It is just to make sure that the airway is placed properly. What they do is they inflate the cuff in esophagus that prevents the aspiration, and the other one is directly going to help in our intubation. Understood? This is combi tube, but basically the most widely used and the most acceptable one is going to be fiber optic in such cases. Okay. Any more doubts? I hope this is clear. If there's something, just let me know. We can go ahead with the questions. Whatever doubts you guys have, just let me know. If anything you want me to repeat, or if there is something else. Anybody? In the next session, we'll be dealing about various methods of fixation and reduction. Okay, so I want all of you to read properly. Next session is going to be all case scenarios based. So I want you guys to diagnose and tell me the treatment plan and everything. Okay, I'm just going to talk about fixations. What are the various methods of fixations? Maxilla, mandible, all of it. What are the plating systems? What kind of reduction is needed? So it is going to be next week itself. So read properly about that. Then we'll deal with individual fractures. Okay, let's go deep into it and spend some time in each of the subtopics so that you guys will remember and not make mistakes. I hope this is very clear. Even if the topics are dry, you shouldn't make mistakes just because the options are a little confusing. Okay? Anything you guys want me to repeat or any other doubts, you can go ahead.